moving from different locations, family, at least I was tempted to eat non-gluten-free food like rice. I was more than 1.5 years, I guess. I was not eating rice, milk, wheat, sugar, corns, and potatoes. These are the 6 items I never touched during 1.5 years.
What about meat? Red meat?
Red meat, I generally don't eat, but I thought that it's better to avoid. So they have a list of items, illegal all items. So I was followed all this, and I came here last January, and I was tempted to eat the non-gluten-free food, and I got little symptoms. Recently, last week, I again went for the colonoscopy. Dr. David Shield did for the colonoscopy here. So because I came to know that there is a little feelings again, it came up. There is a mild Crohn's symptoms came in again. But I need to be on strict diet symptoms. So I have the list of complete chart of my yesterday and water.
Would you actually like to save that maybe for a little bit in the discussion? I just kind of want to get everyone to introduce each other, and then we'll kind of start these topics as well.
My name is Victor Chen, and I'm free of the disease. I'm here really for my daughter. She's had Crohn's for, I guess, 6 years now, and she's keeping it at bay, but then it flares up from time to time. And I came because of the email that I received to kind of understand the disease more. Thank you.
Thanks, Victor.
I'm Stephen Young. I was diagnosed with ulcerative colitis over 30 years ago. Periodic flares, which were mostly, put out with conventional medicines, and a few months ago things just turned kind of for the worse. So I've just begun a Remicade infusion treatment, which very slowly seems to be working. I think I'm actually, for the first time in 6 months, I'm kind of turning the corner a little bit on the disease, which I'm very happy about. But another organization I volunteer for actually did a fundraiser very recently for this foundation, which was the first time I'd ever heard of it, actually. So I think that's how they got my email address, and that's how I learned about the seminar. So I'm eager to learn even more.
Awesome. Thank you, Stephen.
I saw your video online, I think you mentioned in the YouTube something, right? No?
No, I don't remember seeing anything on YouTube.
I'm not sure because your face looks familiar to you. Yeah, I used to spend more than an hour generally, or at least half an hour or a couple of hours in a week time, having to research, deal more.
Yeah.
So what is good, what is not bad.
Awesome. Thank you.
My name is Patrick, and I'm Cameron's dad. And I don't have it, but I think as any family member knows that you have it as well. And she, I guess I'll cut into your story a little, but she was diagnosed with it in 2006 when she was in 4th grade. She's a high school senior now, and I got the email from Ccfa because she's participated in some events, helped at the Camp Gutbusters in Livermore, and I was particularly excited because to have this college-orientated event because she's going to Penn State next fall as a freshman, and there's a lot of angst with her mother and me. I've already checked the health care plan to make sure that there's a, U.S. News and World Report doctor within a period of time, and so, I carry that mental baggage with me. I mean, I want the best, but, so there we have it.
Great, awesome.
My name is Cameron. Yeah, I was diagnosed with Crohn's disease when I was like in 5th grade, and yeah, I was just interested in attending some results in the fall. So.
Awesome, great, thank you.
Good evening. My name is William. I was recently diagnosed in 2011 with Crohn's disease and work here at Stanford University.
Cool. Thank you, William.
Hi, my name is Fazan. My sister was recently diagnosed with Crohn's disease, so I'm attending this to know more about it.
And you said your name was Disan?
Fazan.
Fazan. Awesome, thank you.
My name is Kashvi. It's like Kashi with the V. And I'm here for my sister-in-law, his sister, just to know more, especially about treatment options.
Very cool. Thanks, Kashvi.
I'm Max. I was diagnosed in 6th grade in 2008 with indeterminate colitis. And I'm going to be going to Bowdoin in the fall, so I guess this kind of is applicable to me.
Yeah, very much so. Thanks, Max.
His mom.
Thanks, Mom.
Yeah, I wanted to come learn from him as well.
Awesome, very cool.
And I'm Paul, and I'm his dad. Got the whole family here.
Thanks, Paul. Very cool.
I'm Erica. I'm a registered nurse. My sister has ulcerative colitis and is treated down at Cedar Sinai.
Very cool. Thanks, Erica.
And I'm on mom, and it's for my daughter. She goes to college down in Southern California, and she's just kind of wanted to see what, not only if there's any tips to pick up for her being in college, and she's starting grad school in the fall.
Very cool.
And she is in that, I guess, I look at it sort of the unfortunate 10% that's in that real severe form. And she's kind of on her last leg, as the doctors say, for the medication. So just looking to see if there's anything new coming out on the market for those people that are kind of going to be struggling with surgery as being the last option.
Cool. Thanks for sharing, Irma.
My name's Jan Boynton. I'm going to give you a slightly long story. I was introduced to the disease by antibiotics after my wisdom teeth were taken out in 1971. And I went from not being sick to incredibly sick, flown out of Salt Lake because the doctor told me it was the flu, flown to Detroit, put in the hospital, spent 3 weeks while they diagnosed me. I had toxic megacolon, and I had ileostomy, complete colectomy, and abdominal hernia resection. I was 24, lost 30 pounds in those few weeks, and lived with my parents-in-law, and decided after about 5 weeks that it was like I couldn't live with this anymore. And so in another week I went back to Salt Lake and took up skiing again. I have since skied all over the world. So I want you to know I came mostly to support the effort. I've never had to be reoperated on, with very careful luck, skill, and careful paying attention. I've been to the ER twice only for dehydration, and then a couple of units of fluid really helped. Never any kidney stones, so never any complications. Okay. I wear ileostomy clothes. I never switched to an internal stoma because of my particular hypothesis, because I do fine with this, and I've seen operations, reoperations done the other way around with risks. Okay. Since then, totally unrelated to this, because my husband and I were moving around the world, I decided I needed to do something that was kind of a mystical thing because I thought I would work around the world, and I needed something quick because we were moving too often. So I already had a degree from the University of Michigan, so I signed up for every nursing school within driving distance of Los Angeles, and then went to the local community college and did all the extra science I needed to get into whatever nursing school would take me, and graduated and just spent 35 and a half years, very successful career here at Stanford Hospital as crisis. So I have come to support the effort. And whatever way it can be, I was 24 when this happened, and no one knew not the disease. Very few doctors did. I have a really strange ileostomy compared to today, because this is 43 years later. But you can have a very successful life. I've traveled almost all over the world. I've backpacked all over the U.S. So I want you to know you can travel. It might be a little more difficult getting through the TSA these days with, the things you're supposed to keep in little tiny containers, but a note from your doctor helps. But one can be successful. Now, this doesn't mean it's all simple. There's times where all at once you have to interrupt your life for some reason. I want you all to know. And I support the effort because it's been kind of feeble through the years, getting people to be educated. It seems to be kind of one doctor at a time. And the local programs, sometimes there would be one in the community, but they weren't well publicized. So I did a one-woman campaign as I worked as crisis nurse. Every time I came across a patient with Crohn's or colitis, I would tell them about the organization, and it's amazing how many people don't even know it exists. It's kind of like it's like you either know about it or you don't know about it. And it's not that the organization doesn't advertise. There used to be other organizations called ostomy associations, but they were basically for older patients who had cancer of the colon and then all had ostomies. And so you were kind of a young person with all these elderly people.
Is it possible that because the disease is unknown or that prevalent, that it's misdiagnosed?
I'm going to be addressing quite a bit. So
I want to. Dr.
Because
Shaw's going to have to leave a bit early. Just to
I actually didn't make a very long presentation, but since everyone's sharing their story, I think I'm going to share my story, which I don't share with patients often, and maybe I should. So I've been at Stanford on faculty for 6 years now. I'm a New Orleans native. My whole family still lives there. My story is that Hurricane Katrina hit, and I was in the middle of my GI fellowship, and I realized I needed to do something else. I wanted to get out of New Orleans at the time, and we had lost, all our stuff in the hurricane. And so I went to University of Chicago, and after my GI training, and I actually did a full year of fellowship in just inflammatory bowel disease. And you probably asked me why I did another extra year when I've done so many years of training already. So this was something like 12 years after college that Cameron, this is what you have to look forward to if you go into medicine. It's lots of education, right? And so I felt like I needed to get educated about 2 diseases for another year. And then I was recruited to Stanford to start up the inflammatory bowel disease program on the adult side, and probably seen about 5,000 patients now. So I've learned through my practice. Now, what drove me into doing IBD and what motivated me is because my father had ulcerative colitis. I remember at the age of 8 going on car trips and stopping at every restroom along the way. My father unfortunately developed colon cancer in the setting of ulcerative colitis and ended up getting surgery and got an ostomy and did well. Fortunately, from the chemotherapy that he got, he ended up getting leukemia and he ended up passing away. My sister has a very mild case of ulcerative colitis, is a physician herself in New Orleans, and is doing really well. And she has so I've seen kind of both spectrums of disease, and so I have obviously a personal connection to the disease, and which motivates me to do this every day, day in and day out as a physician. I don't have IBD myself, but I always find it very inspiring to come to these kind of things and be part of Ccfa. I volunteer quite a bit for the Ccfa. I was the committee chair the last 2 years on the Northern California chapter. And I support people like Miles, patients of mine who are so motivated to kind of organize these things. And it motivates me as a physician to want to share my knowledge and try to help in any way I can. So that's my story. I'm going to start. I have a pretty short slide presentation. it sounds like everyone's in different stages of their disease when you guys were kind of introducing yourself and where you are. Some people have been doing well for a while, some people have been battling this for a long, what happened? Yeah. And so what I want to do is kind of curtail the presentation a little bit and just open up to questions because we have a small group and we can do this. I've done much larger patient programs where I can't necessarily be able to open it up like this when we have 300 patients in a room. So I think that will be more helpful to you guys also if I have more question-answer sort of things. My presentation is not going to address every single thing, but it's nice to hear the stories and that you guys are willing to share your stories because I think it's been a while since a lot of patients don't want to share their story and they're embarrassed by the disease or whatever, and it's good to see that there's other people out there. So these are some things that I think you need to know as an IBD patient. This is not comprehensive by any means. This is kind of my nuts and bolts of what you should be kind of asking or understanding about your disease, asking your doctors about your disease as well. So what are some basic facts about IBD? So ulcerative colitis and Crohn's disease are two types of inflammatory bowel diseases. It's a lifelong condition with periods of remission and relapse. And it's a spectrum of disease. And what I mean by that is that we have some people who fall into the category of ulcerative colitis. We have others that are indeterminate colitis. Somebody down there said that you have indeterminate colitis. And what that means is 10% of patients, we just can't classify them as ulcerative colitis or Crohn's disease. So they kind of fall in this sort of gray zone, or my blue zone here. And then the other people have Crohn's disease. And so when we talk about, there's different types of inflammation of the gut, but today we're going to focus on the natural entities. So it really can be diagnosed at any age. There's definitely an increased incidence in the second, third, fifth, and sixth decades of life. So we see people kind of in their teens and 20s start with the disease, and we see another peak in people's 40s and 50s. Get this disease. But I've had even a 70-year-old who walks into my clinic and the first time is being diagnosed, which is hard to believe. I often feel that when they're coming later, they just probably weren't aware of their symptoms as much, and they just thought, oh, no big deal, it has some change in my bowel habit, not anything to worry about. There's definitely an increased prevalence in Caucasians, especially the Jewish population. The total number of cases, 100 cases per 100,000. There's, in the United States itself, 1.5 million Americans. It's a lot. 10,000 new cases a year. So 10,000 people in the United States are getting diagnosed every year. And eventually, these are distributed between UC and Crohn's, so ulcerative colitis and Crohn's. So about half people have ulcerative colitis, half roughly Crohn's, maybe a little less Crohn's patients out there. And this is just in the United States. Now, before I go to the next slide, what's one interesting thing is that we're starting to see this disease in third world countries. And I wouldn't say starting, but it's becoming more common. And as we look around the table, the demographics around our table, we're seeing, some Asians, some whites, and we didn't used to see that. And what we think actually, there's a lot of different theories of what can cause IBD. And we think that there's probably a genetic component, probably an environmental component, probably something in our diet that's causing us to keep diagnosing this disease. But one of the most fascinating things, somebody had touched on what are the new therapies out there and stuff. And, we're doing some research here at Stanford where, we're kind of supporting that poor hygiene hypothesis. And what I mean by that is in third world countries, there's poor hygiene, meaning India, Asia, China, all these places. And as they're westernizing and as they're getting cleaner water and cleaner environments and they're actually westernizing their diet, now they're starting to see this disease. So whereas poor hygiene actually protects you against developing the disease. I think it's fascinating. And so some of you may have, if you're up on the research and stuff, we use worm therapy. That's one of the new research that we're doing is using whipworm to treat ulcerative colitis. So we're running a trial right now as a part of an NIH trial here at Stanford, and I'm the lead on that. And there's 12 centers around the country where we're using for left-sided ulcerative colitis, so a specific person has to qualify for the trial, and using this worm therapy to see if it helps. And there's studies to indicate that it does. So it's just the fascinating part of the field that keeps me going every day is that there's so much out there that we still don't know. So this is a 10, 9, 8 sort of thing, the top 10 things. So we're on number 9 now. So know your disease distribution. So why is that important? So let's talk about if you have Crohn's disease, where's your disease? So the most common locations, so this is your gut, okay? So this is your esophagus, your stomach, your duodenum, your jejunum, and your ileum. That's your small intestine. And that dumps into the colon, and this is your rectum, okay? So somebody had said that had perianal fistulas, that would be down here. So Crohn's can affect anywhere in the GI tract, mouth to anus disease, that's how we call it. So it can affect just certain parts, or it can affect the entire part. 40% of patients, it's just involving the end of the small intestine, the entire colon. 30% just the midgut. Half or a quarter of the patients are going to just have isolated colonic disease. And 5% of patients will also have involvement of the stomach and the first part of the small intestine. So it just shows you how vast this disease can become. And what's interesting about patients who have Crohn's colitis, meaning Crohn's just associated with just the colon, is that they actually respond best to the ulcerative colitis type treatments. So they're kind of a subtype of ulcerative colitis. Now let's talk about ulcerative colitis. So ulcerative colitis, the word colitis means colon, inflammation of the colon. So we're just talking about large intestinal disease. So the entire colon is involved. No other part of the GI tract is generally involved with ulcerative colitis. 30% of patients will just have the rectum involved, 40% will have the whole left colon, and then beyond this area is another 30%. So a third. So it's really important. Now, you may say, why is number 9, know your disease distribution? Well, it's important because when we talk as physicians and we decide on treatments and stuff, we decide where is the disease and where do we need to get the therapy to. So depending on where your disease is will depend on which medications your doctor may prescribe for you. So number 8, recognize the potential etiologies and triggers. So we kind of touched a little bit on this, but we know that there's a lot of different things that factor into why we think we get this, okay? We don't know. There's a lot of research going on. There's probably a genetic component, and we're going to go into each of these in the subcategories. Immune dysregulation, and then there's environmental triggers. Environmental triggers meaning luminal bacteria, infection, diet. There's so many different factors out there that we don't understand and some that we do. So the key point here is that the genetic component is stronger in Crohn's than in ulcerative colitis. And that's why a lot of the gene studies are done more in the Crohn's disease population. So family members of IBD patients have a 30 to 100 times higher risk of IBD than the general population. I gave you my story, right? My dad and my sister. Risk of offspring to the offspring of affected patients. So the chance of me myself getting IBD is 9% because my dad had IBD. The risk of siblings of affected patient, 9%. Risk to parents of affected patients, 3.5%. So Cameron's dad, the chances of him getting IBD because Cameron has it is 3.5%. Identical twins. So you can see how identical twins have a much greater chance of developing IBD than in Crohn's than in ulcerative colitis. So there's quite a bit of research that has gone on, and they're identifying different genes, etc. So this is one of my favorite slides. It's very simple. So this talks about the immune system. Okay, so although the normal gut also experiences local inflammation at times, the key features in IBD is that you have a failure to downregulate an inflamed gut. So the normal person can take that inflammation and downregulate it. When you downregulate, you get a normal gut again. In IBD, you can't downregulate it, and that causes chronic inflammation. So
what does downregulated mean?
So kind of calming yourself, your own immune system can fight off that infection or fight off that inflammation. And so, normally the body would adapt to the inflammation, and after a variable time, the immune system loses its sensitivity to the triggering factors. So that basically higher level of stimuli are needed to basically reinitiate that inflammatory response. So it's kind of like a positive feedback loop. So with IBD, you can't downregulate that inflammation normally, and so it ends up perpetuating inflammation. Another example I give patients is that, say a normal person gets a cut on their knee, And what would happen in that situation? Your body's immune response kicks in. It causes your body to fight off any sort of infection and heal the cut. Well, imagine that cut as your gut. And in IBD patients, you just don't have that ability to fight off that infection or that inflammation. And so you just have this perpetuating inflammation in your gut until something that we give you, or diet, or whatever it is that worked for everybody in this room, is able to actually downregulate that. So, triggers of IBD. What are some triggers? What causes or kind of triggers a flare-up? You know, we talked about it. I noticed when you guys went around the table, there's a relapsing remitting course, right? We know that. And we know that there's different factors. Some will say, gosh, stress. I can tell you some of the college students that come to my clinic, right when finals hit, they're in my office. Hands down, it gets the busiest time is November, December. And I don't know, you did March, so maybe it was freshman year for Miles. You know, you were away from home for the first time. So we know that stress affects this. And it's important just to be aware of that. It's not something to be scared of or to change your lifestyle based on necessarily, but maybe go exercise if you get stressed out, or know how you're going to deal with your stress, especially college and life in general, right? We all deal with that. Infections. So anything can kind of trigger you into a flare-up. You mentioned that you had your wisdom tooth out, you got some antibiotics. You see antibiotics listed right there. So what I always educate, and Miles knows this because he's been to my clinic, is if you need antibiotics, absolutely know that you need them and don't take them for no good reason. There's a lot of, I hate to say this, but there are physicians like me that give antibiotics for cold. Cold is a virus, it's not a bacteria. So make sure, my mom asks for antibiotics all the time. Anytime she's coughing, she's like, oh, I need antibiotics, right? That's not the right way to use antibiotics. And what happens is, we don't know why, but it somehow offsets your gut. And so it's got to be with this bacterial flora, this gut microbiome that you guys hear about and stuff. It's got to be offsetting the bacteria in some sort of way, and it's triggering a flare-up. And so obviously if you need antibiotics, you need to take them, but you don't want to take unnecessary antibiotics. Diet, there's a lot to say about diet. I don't think, in half an hour I'm going to be able to talk about diet. The bottom line is we don't know a lot about diet. I can tell you that I'm faced with this question every day from patients. What we do know 100% is that a low-fiber diet is what we recommend when somebody's having an active flare-up, not because it worsens your colitis, but it worsens your symptoms. So that's hands down. Like when Miles was in the hospital, when you got out of the hospital, I was like low-fiber diet, right? Now, there's other diets, though, too, that may warrant some attention. There's not a lot of funding out there to fund research in this, which is sad, because a lot of the funding is from drug companies. We know that gluten-free sometimes may work for people. Idea is maybe it may calm down inflammation. There's things, some of you guys may have heard of the specific carbohydrate diet. It's a special diet, it's a very difficult diet. So there's a lot that we don't know. I'm not the doctor who's going to tell you that diet is not something to consider. I would just say that as of right now, we don't have a lot of scientific evidence to support it, and so you want to do it in conjunction with conventional standard treatments. To do it alone, you may be taking a little bit of a chance there. Okay. Smoking. Does anybody know about smoking in IBD? Just offhand? Or has your doctor ever discussed smoking? Or do they ask you that? I'm sure they ask you that, right? Yeah.
Isn't smoking with Crohn's disease, it is associated more highly, and then in ulcerative colitis, it's actually less, or like fewer
protective possibly.
Yeah.
So what's interesting is definitely if you're a Crohn's patient, you should never start smoking. You should never pick up even a cigarette. We know that it worsens Crohn's disease. In fact, people get resistant to their treatments if they are smoking while you're trying to treat them with, say, Remicade or something like that. What's interesting about ulcerative colitis is the typical patient that would respond to this is that they have a patient who comes in, they're 25 years old, they were smoking, at 30 they stopped smoking, they finally said, oh, I'm just going to quit, and they start with symptoms, and it's ulcerative colitis. And what's interesting is those patients in particular that started and stopped smoking and then developed symptoms, they actually do better when you put them back on cigarettes. Not that I'm advocating that, but it's another thing that we're very fascinated about. There's studies that show nicotine patches don't work, so it's something with inhalation. So by no means anybody in this room who has ulcerative colitis should be going home and smoking. It's only in that patient who stopped smoking, started with symptoms, that actually does respond. So not the typical patient, not someone like Miles. They go home and smoke. The other thing, this is very important, that I don't know if all your physicians have talked to you about NSAIDs. What are NSAIDs? Non-steroidal anti-inflammatory medicines. What are those? Ibuprofen, Advil, Motrin, Aleve, Tylenol's okay. Those medicines in studies show that taken on a regular basis, meaning you're taking every 4 to 6 hours for a headache or once a month or whatever, can actually trigger a flare-up. And I'll tell you, I bet you a lot of your doctors haven't mentioned that, and it's something that we need to be more cognizant about and make sure we tell people. I've seen those patients, just like you had your antibiotics, started the big flare-up, and you're not the first patient that's happened to. So the same thing when people are taking a lot of NSAIDs, maybe migraine headaches, they're taking a ton of it, that can trigger a flare-up, or just, and so that may make you more resistant to treatment. We already talked about stress a little bit.
So what do you think causes that?
So we think that, prostaglandins. So prostaglandins are inhibited when you're on NSAIDs, and so we think it's this kind of probably similar mechanism to when you get ulcers in your stomach from Advil, is that you're not able to have those prostaglandins, they're inhibited, and so you end up with ulceration. So it's something to be aware of. Number 7, diarrhea doesn't have to always mean that you have an IBD flare, right? So just because you have diarrhea, you're like, oh, I flared up again, I've been flaring up, 3 times a year, really? So my job as your physician would be, is the diarrhea really a flare-up, or is it something else? So let's talk about something else. So the first thing that anybody gets, and I'm sure a lot of you guys have gone through this, is you get diarrhea, your doctor's like, okay, come in for stool studies, and you're like, gosh, not again, right? Not again, I gotta go put a stool in a container and bring it to lab. What a pain in the butt, right? Well, there's a reason for it, because we see a lot of infection. And patients with inflammatory bowel disease in particular are at higher risk for something called Clostridium difficile. Some of you guys heard of that? I don't know if some of you haven't even had it. But it's a common infection that healthcare workers spread it to each other. Spread it to patients by not washing their hands and stuff. So that's one of the risk factors. People who've had antibiotics before are at risk for it. And then people with IBD in general are at higher risk for it. So I can't tell you how many times I've been surprised. Somebody got tested like 4 weeks ago, and then I say, no, let's just do it again. You're having diarrhea. Or they'll tell me, you know what, Dr. Shaw, this doesn't feel like my typical flare. I'm like, okay, something's not right. We get a stool study, and we're able to treat it with antibiotics, and they're better. So that's really important. Number 2, small bowel bacterial overgrowth. What is that? So you have bacteria in your small intestine, and if things aren't moving normally, meaning you have a stricture or narrowing in your small intestine, or things are just slower than normal there, then you can get overgrowth of that bacteria. You get a lot of bloating, you can get diarrhea. Again, there's ways to test for it, ways to treat it. So another thing to be aware of. Medication side effects, right? I mean, some of you may have heard of drugs like mesalamine agents, like Acecol, Lialda, Colazol, all these other drugs, right? Those, some people have hypersensitivity to those drugs. It's a very small percentage of patients, but you can get diarrhea from the medication. Irritable bowel syndrome. This is a little, probably should put a higher percentage there because they had a recent study. So about 50% of patients with inflammatory bowel disease is IBD, right? And then people confuse it with IBS, which is irritable bowel syndrome. Those are 2 totally different diseases, right? 50% of patients will have IBS. And what is IBS? IBS is just hypersensitivity of the gut, that you get scope, no colitis there, you're feeling fine, but you're still having some symptoms. And that's just a sensitive gut. They had a recent study that said that patients who have repetitive inflammation, we wonder if it somehow affects the nerves to the gut, and that you're more sensitive because of that. So it's what your brain perceives as pain, or your brain perceives as diarrhea. So you've heard it, everyone's heard of irritable bowel syndrome, right? You see the commercials on TV and stuff. But just remember that's different than IBD, but it could be a cause of the diarrhea. At times, it's really difficult to differentiate, what the diarrhea, what the cause is. But that's your doctor's, you're supposed to be working with your doctor to figure that out, right? You're not supposed to be figuring this out at home and taking an extra dose of prednisone or anything, right? Okay. All right. So, speaking of prednisone, don't overuse prednisone. How many of you guys in the room have been on prednisone before? And how many of you felt horrible on prednisone? But it made you better, didn't it? Okay.
No.
So, or so prednisone is a steroid, and I call it the all the time eating, shaking, bone thinning, weight gaining, blah making, so you can never sleep again medicine, right? So steroids back in the 1970s, that's all we had. We had steroids and sulfasalazine. I don't know how many of you guys have even heard of sulfasalazine at this point because no one uses it anymore. But we've come a long way. This is 40 years later. We have a lot of drugs. And we're also I'm going to try to briefly talk about what drugs are coming out too. So it's exciting times for us because we're not facing the patient saying, okay, sorry, this is the only thing we have left, or I have no other options for you. That's very frustrating for us. So steroids can be very useful. We use it all the time. Miles, you were on steroids, right? Yeah. And so make sure you're not using it for frequent relapses. It's a temporary medicine. It's supposed to get things in remission, and then you should be on a good maintenance medicine that's a steroid-free medication. Whether that's Remicade, Humira, Imuran, 6MP, Acecol, whatever it is, but you need to be off of your steroids. And I can't tell you how many people come in my office as new patients who have been on steroids for a year, 2 years, 3 years, yeah. So be sure you're not on higher doses than necessary. Generally, for outpatients, you shouldn't be on more than 40 to 60 milligrams. For patients with asthma, we use a lot higher doses. You've worked as a crisis nurse, so you know we use really high doses for asthma. Not for IBD. We don't need to use that high doses. In fact, there have been studies that say that higher doses don't help. So another mistake I see sometimes is that the physicians give really high doses of steroids when there's absolutely no evidence, and then you have a higher risk, right? Your glucose goes up, your bones get thin, you feel horrible. When you're failing as outpatient oral steroids, oral prednisone, then you need to be, and you're still doing bad. I think you mentioned your daughter has the severe kind of colitis before, then you may need to be admitted to the hospital for intravenous steroids. Miles, again, I'm using it as an example because I think you've been pretty public about your story. So, but Miles was on IV steroids and it didn't work. And that's when we had to use Remicade in him, and thank God it worked.
Is Remicade a steroid? No, right?
Remicade is not a steroid. So the only steroids are prednisone, and then there's some other oral steroids that now we have that work primarily in the bowel. That's been great that we have, Entocort or budesonide, and Uceris is a new one that came about a year ago. That was approved for ulcerative colitis. Those are used for just mild to moderate cases, but it doesn't give you all the side effects that prednisone does. So I've been using a little bit more of that in my practice. Be sure you're not on chronic homeopathic doses of prednisone. Oh, my doctor just kept me on 5 milligrams for 10 years, and I've been doing great. And it's a low dose, and it keeps my symptoms under control. It's not good. Something needs to be done about that. And we've kind of already talked about there's so many short and long-term side effects from steroids that I'm not going to go through the entire list. Short-term, increased appetite, GI upset, weight gain, insomnia, acne. I'm not saying there's not a role for steroids. I don't want you guys to get that impression. There is a role for steroids. I use it all the time, but using it in the right avenue. And then you have long-term things like impaired wound healing, elevated blood sugar, delayed growth in young patients, osteoporosis, cataracts, etc. Okay? So that's why we don't use it for long-term. So number 5, IBD can occur outside of the intestines. How many of you guys knew that? Okay, so 20% of patients can get outside of bowel manifestations of their disease. So you may get, come to my clinic, I'll ask you, do you have oral ulcers, any joint pains, any joint stiffness, do you have eye problems, skin problems? And you're like, gosh, Michelle, why are you asking all these tons of questions? Well, because 20% of people get these symptoms. And it could be something as simple as eye inflammation, which could be an eye emergency, redness of the eye, pain in the eye, vision loss. You can get growth failure in children, that's considered outside of bowel manifestation. Some of the patients have a liver inflammation called primary sclerosing cholangitis. Lower bone density, osteopenia, osteoporosis, so sometimes you may be asked to get a bone density test. Skin lesions, you can get nodules, painful nodules on your shin, you can get ulcers on. Now, this is not to scare you guys in any way. This is 20% of patients, 80% never develop this at all, none of these. So 20% is all encompassing. Kidney stones, most common thing with kidney stones, you had touched on this, right? Dehydration. That's the most common, right? Right. So even though we know that kidney stones are associated with Crohn's disease, I don't want to go into the whole pathophysiology of that, but we also know the most common is just not drinking enough water. I don't know if you all have drank enough water to it's so hot outside.
So how would you know you had kidney stones?
Pain,
You will
severe pain.
Well, I don't, my daughter has.
And a blood in the urine. You
Yeah,
know.
and it's incredibly painful.
Very painful, to the point where you go to the emergency room.
Well, no, it's more than,
It's like
it's
labor
more than I want to
pain.
go to bed.
I've
It's
had
like,
labor
I
and
need to
I've
go
had
somewhere else.
I can tell you.
It's incredibly painful.
Okay, because I know people who have it, but that was
Yeah.
just, it's just a.
Yeah,
And
and
you
they
get
can
the-
diagnose it based on urine analysis, CAT scan, there's various ways to look at that. Arthritis and joint pains. Has anybody in this room, yeah,
Is that skin lesions is kind of skin itching?
sorry, which one?
Skin lesion?
Skin lesions?
Oh, no, it depends on which skin lesion you're developing, so it could be
It's not
pain.
itching.
Not necessarily, no.
I seen that itching, only that part, exactly that part. And in 2012, I told to the doctor, and he said, okay, let's go for some blood test. I don't know whether that is the results, but it, blood
So
results
skin,
looks
so
normal.
so itching is not a extra intestinal manifestation generally, but you should talk to your doctor about, that in a little bit more detail.
No more.
Okay. So, number 4, understand the goals and options for treatment. So, by no means am I going to touch on every single drug, but I'll do a little bit of justice to it. So, what are our management goals? What should you expect and how should you feel? Well, inducing a rapid response, right? Getting things under control quickly. Maintaining remission without steroids. Steroid-free remission is what we're looking for. Achieve and maintain complete mucosal healing. That's somewhat controversial. How important is it to have a normal colonoscopy and feel well? Avoiding complications, hospitalizations, and surgery, right? We want to keep you away from surgeons if we can, and sometimes we can't, and then that's the right thing to do. Prevent disease-related mortality. So we don't want anybody to die from the drugs we give them or the disease. But people don't have a high death rate from this disease. This isn't a disease that kills. It's not like heart disease or cancer. This is a disease that gives you a poor quality of life. That's what it is. And so the goal is to improve your quality of life and to lead a normal life. I always tell my patients, I'm like, you should be leading a normal life. If you're not, I'm doing something wrong for you. Okay. So this is how I explain this, and I think Miles has heard this, my spiel on this is to understand the different medications we have and how we use them. It's all about induction and maintenance. Induction means get you in remission. Maintenance means keep you in remission. So when we talk about drugs that get you in remission, we talk about steroids get you in remission, right? It's not a maintenance drug. Acecol, if you have mild symptoms, or mesalamine agents, they may get you in remission, maybe keep you in remission if you have mild symptoms. But sometimes you need the steroids to get you in remission, and then you can use the maintenance drugs. Anybody here on 6MP or Imuran or azathioprine in the room, or know anybody? Okay. So those drugs are great drugs too, but they are maintenance medicines.
Acecol, I have used Imuran. Acecol and Imuran together.
Yeah. So we'll talk about individual cases. I won't be able to talk about individual cases today just because of time, but let me just get through some of these slides, and then I'll open up to questions, so if anybody has any questions, that's okay. So, Imuran 6MP, that's a maintenance medication. It takes 3 to 6 months to work. So sometimes we have to overlap it with steroids to give it time to work. Remicade can be an induction and a maintenance. Some of you guys have said that you recently started Remicade or you've been on Remicade. You get those 3 infusions within the first 6 weeks. That's the part that gets you in remission. Then the every 8 weeks maintains your remission. So if you understand it simply, like induction, maintenance, you'll understand how this disease is treated. And actually, it's not rocket science what I do. So what I'm hoping to do is just kind of touch on some of the subcategories of medicine here. So the anti-inflammatory medications, we talked about steroids. We talked about 5-ASA agents. Those are those mesalamine agents that are the very first line treatment for mild disease. Sulfasalazine, I told you, came out in the 1960s. We still have some patients that don't use it as often. Immunomodulators, we just talked about, 6-mercaptopurine, azathioprine. We also can use methotrexate sometimes for various reasons. Sometimes we use it for treatment, for injection. We do injections for Crohn's disease. And then we have the biologics. Biologics are genetically engineered peptides or proteins that these drug companies have come up with to treat the disease. So that's infliximab, Remicade, adalimumab, which is Humira, certolizumab, which is Cimzia. We have a new one that came out about 6 months ago called golimumab. These are very complicated names, right? Symphony. And then we have natalizumab, which is Tysabri. So we have these are our current options of treatment that are FDA approved. And so here's the different medicines. Here's what's FDA approved for Crohn's and FDA approved for ulcerative colitis. Ileum and the right colon, that's where Entocort can work. Buceris is the new budesonide for ulcerative colitis, where it works in the entire colon. So again, we have other options besides prednisone now, which is really nice. 6-MP and Imurian and methotrexate, they're actually not FDA approved. We use them all the time. You would think that they're FDA approved. Infliximab is Remicade, approved for ulcerative colitis and Crohn's disease. Adalimumab and certolizumab, adalimumab is actually approved for ulcerative colitis and Crohn's disease, which is Humira. I'm just going to talk about brand names because I think that's what you guys probably know. Certolizumab is Cimzia, approved for just Crohn's disease. Natalizumab is Tysabri, which is not an anti-TNF medication like Remicade and Humira are, and that's approved for Crohn's disease. And golimumab, which is the new drug, Symphony, is approved for ulcerative colitis. So number 3 is weigh the risks of taking and not taking your medications. So another big mistake we see is that patients like, I felt well, I stopped my medicine. But they felt well because of their medicine. And so it's easy, I'm sure it's very easy to do that. I'm just thinking, I'm not very good about taking my vitamins every day, So I think it's pretty simple to do that. It's you feel well, so you're like, I don't need these anymore. They have risks. I don't want to take the risk of these medicines, but 80% of people in the first year stopping their medicine actually flare. 80%. So this is not a disease you get rid of. It's a disease that you put in remission. It's not a disease you get rid of, unfortunately, unless you have a colectomy. Colectomy is the only cure for ulcerative colitis. So there's no cure for Crohn's disease. Surgery, you have a risk of it coming back.
Now, let me say though, you can never get an appendicitis if you have had a colectomy. And you can never get colon cancer. So there's a few advantages.
That's absolutely right. So these are some of them. This looks like an extensive list, and it's not the purpose of this slide. This is the mesalamine agents. Very mild. They generally are well tolerated, but these are some of the risks that they do associate with it. And some of these are acute risks, and some of these are chronic risks. But mostly, once you're tolerating, you do fine on it. I'm going to spend too much time on it. What about azathioprine or 6-mercaptopurine? So roughly about 10% of patients will stop the medication because they're not tolerating it. You can get an allergic reaction to it. 3 to 4% of patients will just get an allergic reaction to it. That's usually immediate. If you've been on it for a while, you're not going to get an allergic reaction generally. That would be a fever, rash, that sort of thing. You can get GI upset, nausea. Fatigue is a common thing that people feel on 6-MP or Imurian. You can get liver toxicity, meaning your liver function test could go up. We're monitoring all that. You should be getting labs every 3 months at least. Infection risk goes up, usually more with the azathioprine 6-MP compared to the anti-TNF like Remicade. It's more viral infections, so you may have more of the flu a little bit longer. That's why it's really important. I have another slide on this, getting all your vaccinations updated when you're on immunosuppression. Pancreatitis is a rare complication. That's inflammation of one of your digestive organs. Bone marrow suppression, meaning low light count, low blood count, that sort of thing. That's being monitored. All of that, even when you're on Remicade, Humira, Imurian, 6-MP, whatever it is, you should be getting blood work every so often. Generally, my practice is when you're on Humira, Remicade, or Cimzia, or any of these other drugs that are anti-TNF agents, you get blood work every 4 to 6 months. If
you're on azathioprine or 6-mercaptopurine or methotrexate, every 3 months. If you're on just mesalamine agents like Acicol or something, once a year kidney function test. Malignancy and lymphoma. Let's talk about that. Okay, that's probably the scariest, right? We talk about infection and lymphoma. So, and when we talk about lymphoma, we need to talk about numbers, and you've got to understand the numbers. So baseline risk, if we had this whole room was filled with 10,000 people, which you can't imagine 10,000 people in here, but there's 10,000 people in this room. 2 out of 10,000 develop non-Hodgkin's lymphoma. Normal, baseline, not being on any of these medicines. When you're on azathioprine or 6-MP, that baseline risk goes up to 4 out of 10,000. Okay. It doubles your risk, right? So if the doctor told you, when you get put on this medicine, it's going to double your risk, whereas I just told you it went from 2 to 4. Your understanding is much deeper when I say 2 to 4. Okay. When you're on drugs like Humira, Remicade, Cimzia, these kind of medicines, that risk goes up to 6 out of 10,000. Now, unfortunately, we don't have data on just Remicade and Humira alone. The 6 out of 10,000 number comes from people who are on both 6-MP and azathioprine with the Remicade or the Humira or the Cimzia or the Symphony or whatever. So, if you and then the other thing when I teach a lot of fellows, understanding your risk of dying from a natural incident in life. What's the risk of dying from cancer in general? 1 out of 8. What's the risk of dying from a motor vehicle accident? 1 out of 260. So you see, if you don't understand the numbers, these drugs can really, really scare you. And I can understand that, but if it's not explained on that level, if you go to what is the risk of getting struck by lightning or things like that, you'd be surprised that the numbers are actually more favorable for lymphoma. Okay, so anyway, it's not to convince you to take medicine. That's not my job here today. It's more just to educate you about the questions you should be asking your doctors. What are these risks? What are the chances we develop this? Okay. So these are the risks of biologics. Biologics are that whole category of medicine that we talked about: anti-TNF medication, Remicade, Humira, Cimzia, Symphony, that sort of thing, and natalizumab too. So there are some. There's the list. If you open the drug insert, it's really scary, right? But there are some risks that are just some case reports out there. What I mean by case reports is there's like 20 cases out there worldwide says that people can develop heart failure through drug. They have to put it on their package insert. Okay, there's about 30 patients out there that worldwide, but there's millions that have been treated that develop multiple sclerosis. That's scary, right? So again, some of these things are just case reports. Heart failure, demyelinating disease, brain infection, things like that. And there's some that are real. So we already went over lymphoma. There's also an increased risk of skin cancer with being on 6-MP azathioprine in particular. You can get any sort of allergic reactions to infusion, to injections, bone marrow suppression, infection, and so forth and so on. Okay, so
Bone marrow suppression?
Meaning low white count or low blood count. So that's why when your doctor's getting your labs, they're looking for your white count to be stable, your blood counts to be stable. Because remember, we're trying to actually suppress your immune system by these drugs. That's the whole purpose. Because if we suppress your immune system, then it doesn't get overactive. So with that comes these risks, unfortunately. So we kind of went over some of this already. This is to educate you about what labs your doctor should be getting on you. Okay, so if you're on like any of the mesalamine agents, which are called 5-aminosalicylates, which is Acicol, albuterol, Preso, all those medicines, you should be probably getting a kidney function once a year. There's no guidelines on that, but there is a rare risk of interstitial nephritis, which is a kidney allergic reaction. So just make sure you're getting your kidney function once a year. Before you start 6-MP or azathioprine, we get an enzyme level to tell me how you're going to metabolize the drug. 0.3% of patients can't metabolize the drug at all. 11%, we just got to use a lower dose. And 90% can metabolize it just fine. So that's important. We get that. That takes a week to come back. And then we monitor your blood counts and stuff. So we may get blood work I do it every 2 weeks at first, then a month later, then every 3 months. But minimum every 3 months. I only give my patients prescriptions for 3 months so that when they run out of their prescription, it's kind of an alert They have to come for their blood work. Sometimes we have to measure levels of the 6-MP or laser bioprint. Say it's not working. Why is it not working? Can we measure levels? Are the levels low? That sort of thing. And that's something at the discretion of your doctor. Methotrexate, if anybody's on methotrexate, you have to get lab work every 3 months. In addition to the standard complete blood count and liver function test, we have to also get kidney function. Biologics are the anti-TNF medications that we talked about, Remicade, Humira, Simpson, Symphony, all those. We have to get a TB test before starting, because we can reactivate TB if you've had any exposure to TB before. We also check hepatitis B. We can reactivate hepatitis B, so we check you for hepatitis B. And then we also, I usually get blood work every 4 to 6 months, but generally every 6 months. Steroids, if you're on steroids, you want your sugars to be checked every now and then. It depends on your situation, what your risk factors are. I put here vitamin D. How many of you guys have had your vitamin D checked? It's like the newest thing that everyone's doing, probably the last couple of years, right? Even people without IBD should have gotten their vitamin D checked. So the reason why is there's multiple studies out there now that indicating that low vitamin D level is higher risk of cancer, higher risk of cardiovascular disease, and also improves your immune system if you have normal vitamin D levels. So everybody in this room, whether you have IBD or not, should be getting their vitamin Ds checked. I have low vitamin D. I've been on high dose vitamin D, and I think my husband swears that he doesn't get sick anymore ever since he replenished his vitamin D. So, for whatever it's worth. So, IBD and intestinal complications. So, what are we trying to prevent here? We're trying to prevent complications like hospitalization complications, improving your quality of life. So, these complications, so strictures, narrowings, strictures can develop from inflammation over time, and it causes scarring. You can have fistulas or abscesses. Fistulas are abnormal communication between organs that aren't supposed to be communicating, like bowel to bowel. We have patients who come with bowel to vagina, where they have stool coming from their vagina. You can have stool coming in your urine. There's a lot of, and that's a complication of Crohn's that many of you hopefully will never see. But that's what we're trying to prevent, because we've seen those patients. And if you develop a fistula, you're at risk for an abscess. Abscess is a pus collection, and that develops from the inflammation, kind of burrows through, cause these little fistula tracts, and then you get these little abscesses, which is pus collection, that can make you very sick, actually. Toxic megacolon. You mentioned you were helicoptered or flown out.
Yeah, and surgery was the only, because everything wasn't
You're
like
very,
the entire
very, very sick.
colon. So actually, at the end of the small intestine, all of the colon and the rectal area. So there was no option to treat with medications.
Yeah, and the colon's generally dilated, and you're very sick.
Yeah, it was going to
Very
explode.
sick, meaning fevers, your blood pressure's low, you're in the ICU. So this is another complication, not to scare you, but this is, if colitis doesn't get controlled, this is one of the risks, and these are the things we're trying to prevent. And most people don't develop any of these. This is not to scare you in any sort of way, it's just to educate you about what can happen if we don't treat the disease. Perforation, you can get just a frank hole from all the inflammation. You can imagine that inflammation over time, what it can do. And then cancer risk. You have an increased risk of cancer when you have colitis involving your colon, whether it's Crohn's or it's ulcerative colitis. But if it's affecting the large intestine, your cancer risk goes up, your colon cancer risk goes up. And so what's the risk of ongoing disease? We talked about risks. We've been talking about risks and risks, right? What if we don't treat these? So Crohn's disease and surgery. Within a year of diagnosis, 40% will have surgery. Within 5 years, 50%. Within 20 years, 80%. That's if it's untreated. These numbers are people who were not treated. Okay. Ulcerative colitis surgery. Within 20 years of diagnosis, 20% will do surgery. And disease leads to pain, uncontrolled inflammation, and repeated courses of steroids and pain medication. Right? So these are risks too. And what's interesting is they did a large study of 10,000 IBD patients, and they looked at narcotics, which are pain medicines. 2, they looked at steroids. They looked at Remicade, and they looked at 6-MP. And guess who had the highest risk of infection? The narcotic and the steroid group. Right? You'd think it would be the Remicade. You're getting IV infusions, of course. You're suppressing your immune system. It was actually the other 2 groups, and a pretty significant increased risk compared to the other 2 groups. So understand your risk of colon cancer and how to prevent. So The colorectal cancer risk, this was a study of 116, they actually took 116 studies together, and they did a meta-analysis, so it's a very, very large amount of patients. And the overall chance of developing new onset colorectal cancer increased over time. And the probabilities were about 2% by 10 years, 8.5% by 20 years, about 18% by 30 years. So the way I usually tell patients is that you increase your risk by roughly 5 to 10% per decade. And so, what are some other risk factors for cancer? Well, one, the longer you have the disease, the greater the extent of disease. So somebody has more of their colon involved, they're at higher risk. You have family history of cancer. You have this liver condition. Remember I told you there's some liver inflammation that can be associated with this disease. That's primary sclerosing cholangitis. You have a stricture, a narrowing in the colon. You have pseudopolyps, or you have active disease. So this is one of the reasons why your physician will say, oh, we need to treat your disease, because we want to get those risk factors down, right? Because we're the ones who see 30 years later, we see a cancer cell in someone's rectum. So if you take your medicine, you're in remission, your risk is low, very low. And that's what's important. So this is a busy slide. I'm just going to summarize very quickly. So after 8 years after symptom onset, these are people only with their colon involved. If you've only had small intestine involved, don't even worry about this slide, okay? These are people who've had colonic involvement, more than a third of their colon involved for Crohn's, or their entire colon involved for ulcerative colitis, or part of their colon involved for ulcerative colitis. After 8 years after symptom onset, what I do in my practice is I scope the patient for the first time, or in recurrent time, whatever it is, and see where their disease distribution was. Like I just kind of do biopsies throughout. Generally then, the guidelines say, depending on how much of your colon is involved, every 1 to 2 years you should get a colonoscopy. We now have a special dye procedure. Has anybody heard of chromodoscopy? Blue dye? So it's got a lot of hype in the last couple of years, where we spray this blue dye in the colon, none of it gets absorbed, and helps enhance any abnormal lesions. It's an accepted alternative to taking multiple biopsies. And so we do it at Stanford, but it's to look for, it's basically to help us look for abnormal lesions so that we can detect them early. Okay, number 1, stay healthy. So this is my last slide, okay? So what can you do on your own? Things that you can control. Obviously you can't control your disease. You can't control the fact that you got your disease, right? But you can do some things to you're doing one today, right? You're educating yourself. You came to this evening program, listen to my talk. Hopefully that wasn't too boring. But then there's other things you can do. You can make sure you're getting your labs. Are you educated about how often you should be getting your labs, or you should ask your doctor, okay? Nutrition, being on a healthy diet, eating well, right? I mean, the Ccfa provided us some healthy food here, except for the chips, right? But some fruit, and, having a healthy diet. If you're well, generally most people are able to eat normally. If you're not well is when you start wondering if something's wrong, right? I remember I already shared my story with my dad, but I remember he was always on a bland diet, always like when we were growing up. It's like I never understood why my mom was always making really bland food for him, because he wasn't well. Because if he was well, after he got his ostomy, he was eating normally. Yeah. So remember that. I mean, I know diet does play a role. I 100% say diet plays a role. I'm not, like I told you, that person who says that diet doesn't play a role. But, if you're using diet alone, just be questioning, is it just a period of remission, you're just feeling well, or is it really just the diet? Vaccinations. How many of you have had a discussion how many of you are immunosuppressive medications first? Meaning azathioprine, 6-MP, steroids, or one of the anti-TNF medications? So a couple of you. How many of you guys, your doctors have talked to you about vaccinations? Well, that's because I know I'm your doctor, so I know the people are raising their hand. So vaccinations, how important are those? Really important. So we already said that your infection risk is high, right? So what can you do to prevent it? Get your flu shot every year. You make sure your household members get your flu shot. So when you have a roommate, make sure they get their flu shot in college. Okay? You don't get sick. Second thing is getting a pneumonia vaccine, believe it or not. So that's not normal for doctors to tell you that, but you need 2 pneumonia vaccines 5 years apart. and then after age 65. So you just need 2. That's it. Okay. Third one is tetanus booster. Tetanus booster every 10 years. And that's for everybody. That's everybody in this room, whether you're a parent of an IBD patient or you have IBD yourself. You should also get a hepatitis B series. Females 26 years of age or younger should get probably the HPV vaccine. What else? I'm thinking, what else? That's about it. So what's important here is if you're already on immunosuppression, you can't get any live vaccines. The ones I just listed are all dead vaccines. And why is that? If you take a live vaccine, you can actually get the disease from the vaccine. So, say you take a chickenpox vaccine, or a yellow fever vaccine, or a polio vaccine. Those are live vaccines. Your doctor should know what a live vaccine is. So anytime somebody gives you a shot, make sure it's dead. If you're immunosuppressed. If you're not immunosuppressed and you're just on Asacol, that's fine. Take whatever you want. Okay, but these are patients who are on 6-MP azathioprine or the biologics. Cancer screening. Cancer screening we've already talked about. Cervical cancer screening. So believe it or not, there's multiple studies out there that say that you're at higher risk for cervical cancer if you're immunosuppressed, meaning HPV-related cervical cancer. So the guidelines, according to the Gynecology Society, says get your pap smear every year. So just talk to your doctor about skin cancer. I ask everybody to get seen by a dermatologist on a yearly basis. On a yearly basis, get your moles checked, because drugs like 6-MP azathioprine especially have a higher risk of developing skin cancer with this. Breast cancer, that's the usual stuff, prostate cancer, I'm not going to go into all that. Tobacco cessation, we talked about smoking and how cool it is to smoke, right, or not smoke. Forget that.
Yes, to your point about skin cancer,
Yeah.
while everyone should avoid the sun,
Sunscreen.
especially though if you're on an
Immunomodulator, yeah. And especially, extra especially if you're on azathioprine or 6-MP. And wearing sunscreen. So obviously if you have darker skin, someone like us, we're a little bit less risk, but wearing that sunscreen is really important.
What is 6-MP azathioprine?
6-MP azathioprine is some of the drugs that I was talking about before, which was the immunomodulating drugs.
Is that azathioprine, which is called Imuron also?
Azathioprine is the generic, Imuron is the brand name.
Yeah, 6-MP azathioprine
Is 6-MP and azathioprine in the same class of medications? And what happens pharmacokinetically is that the azathioprine actually converts into 6-MP. So both are the same drug. Think of it as the same drug.
Okay.
They are actually different drugs, but they're the same class. There's not one that's better than the other. They're all the same class. They're both immunomodulators. Bone health we've talked about. So some of the risk factors and other things. Since I just told you guys about vaccinations. If you've had steroids for more than 3 months, repetitive courses of steroids, you're at risk and you need to get a bone density test. You should be taking calcium and vitamin D when you're on steroids as well. Blood pressure screening, the reason why I put that on there is because when you're older, you're taking steroids to raise your blood pressure, depression, and anxiety. I don't want to make light of that because I think this is a disease that really affects you. A lot of young, old, it creates a lot of anxiety, and it can make people very depressed when they can't get their disease under control. If you're a family member, be as supportive as you can. As a doctor, I have to be as supportive as I can. I gotta remind myself that this can happen to anybody, and but we can overcome this. And there's ways to overcome it. And make sure if you do have this and you haven't talked to your doctor about it, make sure you talk to your doctor about it. Ophthalmologic screening is just an eye screening, so just get your eyes checked once a year. And make sure it's not just an optometrist. In my opinion, it should be an ophthalmologist. So. Okay, so I hope you're not going to be like the 20 incompetent doctors who can't find anything wrong with me. And so, do you want to play primary health care provider? So, you have a medical team, and it's coordination of care. I can tell you that I'm on the phone every day with my surgeons. They're either calling me about a patient or I'm calling them about a patient. I make sure everybody has a primary care physician. And then I make my recommendations, say make sure you get your vaccinations right, make sure you get your bone density. I tell them to go see their gynecologist, if they're at higher risk for cervical cancer. So the point of this slide is it's a team approach. And I can't do my job without the other doctors that are there. And I'm always humbled by what I can learn from them and from, most importantly, you guys. So that's the end of it.
One more comment, people just having the 43 years perspective on this. It's a chronic disease, so even in my case where I lost, have the ostomy instead, you must pay attention all the time. And so your psychological health is absolutely important, that you don't get too frustrated and kind of like, to hell with it, I'm not going to do this anymore. In various ways, like where anything from double up your doses to not do your doses to you get tired of going to appointments, and so I'm going to go to, Mexico and try some new treatment, okay? You must follow up. I mean, even in my situation, I lost the disease, but I still ended up with the ostomy and various things to watch for. And so everything from the eye doctors to the skin doctors to the nephrologist, etc., because there's these risk factors, and you must keep track. It helps you grow up. You don't have to be super serious. It's a disease that it has secrecy involved because it's things people don't want to talk about, except if you're kind of in a safe group. And so you get scared, okay? And let me tell you, I've survived in these years. I've survived a few things I never thought I would, in the sense of embarrassing incidents, where you're like, oh my God, I'm in the Bahamas and this is happening to me. And you're like, how am I going to, how are you going to go from what you thought was a great, holiday to all at once you're having like this disaster. And so if you need therapy along the way, I don't mean everybody needs to go on antidepressants, but get training in mindfulness, imagery,
a lot of programs.
Lots of programs. You don't have to take up yoga, but come up with a whole bunch of things, a big toolbox for yourself. I mean, also that stuff about talk with friends and family, but you need it for yourself too, because there's times where you need to go, maybe I'm just going to get through the day, okay? I'm just going to make it through the day, because you're going to be doing this for the rest of your life, okay? So I urge you.
You had a question? You wanted
to go ahead.
One thing I didn't touch on was new therapies coming out, and it's a whole, I gave a talk, an hour-long talk on this the other day. So just briefly, there's a new drug called vedolizumab that's coming out. Hopefully, if the FDA approves it, they're going to make a decision on May 20th for ulcerative colitis and on June 19th for Crohn's disease. Looks like a promising drug. The beauty of this drug is that it's gut specific, so it may have less risks. I'm not suggesting this people who are doing well on their therapies. Okay, you don't want to switch therapies if you're doing well, because you don't know if you're going to respond to the next one. But people who are like kind of losing hope or don't know if they're going to need surgery, it may be something to talk to your doctor about. They're literally coming out in the next 1 to 2 months if they get FDA.
What's the name, or how do you spell it?
Vedolizumab, V-E-D-O-L-I, I should know the brand name, I don't, C-U-M-A-B, V-E-D-O-L-I-C-U-M-A-B. There's another drug probably next year or two that's going to come out called Stelara, S-T-E-L-A-R-A. It's approved for plaque psoriasis already. Crohn's disease trials look good. I've on luck gotten insurance companies to approve it when I had nothing else to use on some of my patients, and I have a couple of patients doing well on it, a couple. There's another drug for ulcerative colitis that's coming out that's going to be an oral agent. That's going to be like the biologics, but it's the oral. It's going to be our first oral agent that looks promising, probably in the next 2 years. Just so you understand how our studies are done and how it goes into FDA approval. It's a 10-year process, 10 to 20-year process. So the minute they start with trials and the minute the FDA approves it, the average is 10 years. So you can imagine it's not overnight that we've had all these drugs, in our options. But those are the most immediate things that look promising, look like they may come out, that, if you're running out of treatment options, you can maybe ask your doctors about and see if they can convince your insurance. I've written pretty strong letters sometimes to convince insurances. Especially for the Crohn's patients, because you want to try to avoid surgery at all means. Not that you don't want to in ulcerative colitis patients. But you had a question?
Yeah, I had a question about Is treatment for Crohn's mild to moderate with constipation the same as you would treat it for people who have the more general symptoms of diarrhea?
Yes.
And it's the same?
Generally, you're treating the inflammation. And the question is why somebody has constipation over diarrhea. And, you know, I've had patients have really severe disease that feel fairly good, and then they present with one of these complications. So you still got to treat the active inflammation generally. And, you know, people with strictures or narrowings that we talked about can have constipation because it's not able to get through that area because it's like a narrow pipe.
Okay.
Some people have typical symptoms. I mean, typical symptoms obviously are abdominal pain, diarrhea, fevers, weight loss, that sort of thing, but not everybody meets the textbook picture always.
And how do you feel about introducing probiotics, like a brief?
Yeah, so there's a lot of studies on probiotics, and I think there's a role for probiotics in a specific patient population. So where I think it has some validity is that if you have IBS symptoms, we talked about irritable bowel syndrome, and you know it's not your IBD. There's specific probiotics for that. So believe it or not, in our field, there's actually specific probiotics for every disease. It sounds crazy, right? Because you go to the Whole Foods and there's like this whole wall of probiotics, right? And you don't know which one to pick. But there's actually studies on each of these things. And for IBD in particular, ulcerative colitis in particular, Crohn's patients, it was not very effective, the probiotics. So could it help you restore your gut flora? Could it help you make you feel a little bit better? Sure. But it's not going to probably help with the inflammation. But for ulcerative colitis patients, they have some studies that say that in conjunction with standard treatments, especially when you have mild disease, when you're on just Acecol, I often will add a probiotic to that before I go to the immunomodulators. If I have the luxury of time, if they have mild symptoms, if they're, you know, not too excited about going to the next step in treatment. And that particular one that's been approved or has at least the most evidence for ulcerative colitis is VSL number 3. And so I do use that. Does it work or not? Mixed. I don't know. I'm not convinced it's the miracle probiotic, but yeah.
Are all signs of inflammation different for everybody, I assume? Or is
all
there
symptoms of inflammation?
Yeah. I mean, I could ask you once, maybe.
So you can get just anemic from active inflammation and not have really bad symptoms. Some people have like very bad diarrhea and end up in the hospital. So it sort of depends. So the short answer is yes. It can be very individual.
How do you check for that? Can you check for that?
Check for what?
Inflammation.
Inflammation, yes, by scoping or and if it's not reachable by scope, then doing imaging tests is another way that we look for inflammation.
Do you do cameras?
We can sometimes. It's appropriate in certain situations. There's just we just got to do it carefully because cameras can get stuck.
Right.
So it is appropriate to do it in the right setting. Okay, so let me read this. Could you make copies of your presentation and available to us? That's an easy one. Yeah, I can. What I'll do is I'll email you and we can post it.
I'll send it to all.
Does smoking marijuana help or hurt IBD? That's a good question. So there's some recent studies that say that marijuana use may be helpful in Crohn's. That being said, the study was a small number of patients, very small number of patients. And the problem I had with the study was that the way they assessed response was by symptoms. And so we know that marijuana is going to make people feel a little bit better, make them less nauseated, or make them feel better in some ways. And so I didn't think that it was a very controlled and a big enough study to make a conclusion on. This brings up one more thing. There's a very, very good website. I love the Ccfa website for sure, and I'm very involved with Ccfa, as you guys know. But there's another website that I absolutely love that I tell patients about called You and IBD, YOU and IBD. If you Google it, it's just a bunch of experts, IBD experts, doctors actually on there doing slide presentations, doing videos about IBD, and every single possible question you could ask. Marijuana, there's actually a little segment on marijuana. So it's just interesting to hear the dialogue, and then you're not reading all these blogs because you know how dangerous blogs can be, right? I'm sorry if I offended somebody who writes for blogs, but is there any progress towards a non-surgical cure? There are some vaccinations being studied. They're looking up with actual cure. There's stem cell research being done. So there's a lot of stuff. I think there's a lot of money now going towards IBD research, especially when you're talking about 1.5 million people in the United States and 10,000 new cases a year, so that's a lot. Yeah.
One of the things we're hearing a lot about in the news is fecal transplants.
Yes, I can talk about that briefly. So fecal transplant has been FDA approved for C. diff colitis. We talked about C. diff as a bacteria that you're more susceptible to, but recurrent C. diff. Now they're doing studies on ulcerative colitis. They've already done pediatrics study. Again, small number of patients. It looks promising, okay? But the problem with studies is that you need larger number of patients, larger number of studies to be done. And there's 3 ongoing trials in adults going on right now. If you guys ever are curious about clinical trials of what's going on, if you go to clinicaltrials.gov, G-O-V, it will list every single clinical trial that anybody's associated with that we're supposed to report what trials we're doing. And so if you're ever at you've already figured out everything, you can't get surgery, you can look in and see if there's a clinical trial in your area. But there's actually 3 clinical trials on there in adults right now. So I don't know. We'll see where fecal transplant goes. It's exciting. I think there's some promise for it. The studies that were already done were in ulcerative colitis patients, so we'll see where it goes. I don't have a yay or nay on it yet. I think it's encouraging that people are doing these studies. Believe it or not, fecal transplant, you have to have, now the FDA is requiring us to do a ton of paperwork to be able to do it. So even if you did 1 case at Stanford, 2 cases at Stanford, we're not technically allowed to do it anymore without that paperwork done. And the process of applying for that paperwork is a huge process. And so there's very few centers now that are doing fecal transplant off-label, I'm talking about. How does malaria medication affect IBD? I don't think it does affect IBD that I know of. Traveling. The only thing about travel, I know this is a very common question because I take care of a lot of students. It goes back to the vaccinations because yellow fever is if you ever want to travel to Africa, you can get the live vaccines, but you got to get it a couple months before you start the immunosuppression. So you can't be so sick that you need the immunosuppressive medications. You don't have that luxury of trying to get your vaccination. So I have lots of patients who travel with their medicines. I have a patient going to Paris this summer, Spain, and they're going abroad from Stanford as undergraduate students or graduate students, and we figured out how to get them their medicines, and we figured out how to hook them up with doctors in Europe, and we've gotten everything figured out. So you should lead, this goes back to leading a normal life with IBD. It should not be restricting you. Yeah. If you're well, you should be leading a normal life. Yeah.
What are the odds that the disease will morph into a different type of...
Yeah, so I don't know what the percentages, quite frankly, are, but there's two things. So one is that there's some patients that maybe weren't diagnosed correctly to begin with, right? And that's a small, I hope that's a small subset of patients. And then we talk about a spectrum of disease. So we do see sometimes where people, you swear, I've had a patient one time, like, definitely ulcerative colitis, no doubt in my mind based on the scope. I scoped him myself, I biopsied him myself, very confident, and then they ended up with Crohn's disease. So you can't, we don't know, it's a small percentage, very, very small percentage. So I don't know if you guys have heard of a J pouch, but what a J pouch is when somebody takes out their entire colon and they take their small intestine and they sew it to their bottom. It's a way to cure ulcerative colitis, but it's a way to not have an ostomy in younger patients, meaning 65 or less. And those patients, when you should not get a J pouch if you have Crohn's disease, you cannot get a J pouch. But I've had about 2 to 5% of patients will have a J pouch and then develop Crohn's disease of their J pouch, and that is a very difficult disease to treat. I have quite a few of those in the clinic. Any other questions?
This has been fantastic, Dr. Schultz. Thank you. And it actually gives me great reinforcement for the care I'm getting, because many of the things you're saying are absolutely consistent with what my doctor was saying about, kind of what's in the pipeline and all that. But I have 2 particular questions. The first deals with diet. And I appreciate that there may not be any evidence or enough empirical evidence to draw conclusions, but caffeine and sugar.
Absolutely. So caffeine increases the motility of the gut. We know that.
I'm sure it
increases the motility of the gut. Okay. So when somebody, I don't know how
many. What is motility?
Meaning you drink a cup of coffee and you have to rush to the bathroom. Normal patients, right? It increases the activity of the gut, I should say, instead of motility of the gut. So it increases diarrhea. So it kind of goes back to that fiber thing that I told you is that when somebody has active disease, you shouldn't take fiber, not because it makes the inflammation worse in any way, it just makes your symptoms worse, right? It makes you go more. Same thing with caffeine. So generally we tell people to avoid caffeine. The other, I'll expand on your question a little bit more than what you asked. Dairy. People will ask, oh, what about dairy? Should I take dairy in my diet? Should I not take dairy in my diet? Well, what I've found in my practice after practicing for a couple of years now is that I find that when people are in a flare-up, for some reason they avoid dairy, it makes them feel better. And then once they're well again, they're able to reintroduce dairy, unless you're lactose intolerant from the beginning, which is a totally different scenario. So I do think that dairy plays some sort of role, but I've seen in my practice that it's more in the acute situation when you're flaring up when you're not well. Third is gluten. We've talked about gluten a little bit. Gluten is known to cause, or we think causes inflammation in the gut. Okay, so how that plays into IBD, I can tell you 100%. Multiple patients come to me and say they feel better on a gluten-free diet. I'm not going to argue with that. It makes them feel better. They're not losing weight to a bad level, and as long as you're not losing weight, I'm okay with you doing it. So I think there may be some warrant to telling people to do gluten-free sometimes.
I was on with severe health condition. I went to 40 kgs. So I even Remicade did not help me out. When I start the gluten-free food, very strict, I went up to 60 kgs.
Yeah, so it can very well work for some people. Just remember that diet alone isn't going to necessarily control your disease in most patients. And the other thing you want me to touch on is sugar. So, I mean, there's a lot on sugar. You can go to YouTube and there's tons of videos that convince me not to eat sugar and it's bad for me, but you still do it, right? So what do I know about sugar? So one thing we know is, this goes back to that specific carbohydrate diet that I was talking about. We're actually doing research on that. The pediatric division is doing more research on specific carbohydrate diet. We're collaborating with them. The premise of the specific carbohydrate diet, and if you guys have ever heard of the book Breaking the Vicious Cycle? Yeah.
My daughter did the specific carbohydrate diet.
It's hard.
It was, but she was probably the healthiest she's ever been in her life.
Yeah. So it works for certain people. So yeah, one story that worked. There's some people it may not work, or it may not work because it's too strict of a diet.
But then you go to college and things change. It's really hard. It's a very difficult. Probably one of the most difficult diets that I know of.
That's interesting.
But, yeah.
And it's worked for a lot of people. So that's where I say that I don't discount diet, because I think sometimes it works for people as long as you're not losing weight on it. So the premise of the specific carbohydrate diet is that you're eliminating disaccharidases. So what is disaccharides? Complex sugars. And we think that because the IBD patient can't break down those complex sugars, that builds up in their system and causes inflammation. That's the premise of it. No one's ever done mechanistic studies on it, but that's the premise. So one, we know that sugar makes you feel bloated sometimes. Sugar is associated with, there's studies out there to say that sugar can help with multiple sclerosis if you decrease the amount of sugar with a specific carbohydrate diet in IBD patients. So I think there is something to say about sugar, but it's different than caffeine, going back to your first question, right? Caffeine is just increases your gut activity. Whereas sugar, I think there could be a role, just like gluten. It's just that how restrictive do you get? What's reasonable? Especially, we're on campus right now. We have young patients in this program that are in college. Your daughter, you're talking about going, how realistic? So I think every patient's different in what you're willing to try. I think whatever you do, just talk to your doctor. Don't necessarily, there are some doctors who are going to be like, no, don't do that, whatever. But at least have the dialogue and conversation with your doctor, because they may know something that you don't. So that's one thing I would recommend. That's kind of everything I know about diet.
Thank you. And I had one other question. This is my last question.
Yeah.
Is there any evidence to suggest that these diseases are communicable in any way through intimate contact or activity?
Absolutely not. Zero.
That's what I've been told consistently, and that seems counterintuitive to me.
Because it's a fecal sort of disease. Yeah. But we haven't identified any bacteria or anything transmittable. There's mycobacterium that's been possibly associated with Crohn's disease, but that's still being studied, and the jury's still out on that. Yeah.
Thank you.
Then you had a question? Cameron's dead.
You.
No, I can't. Just listening to you.
You raised your hand.
I did. Well, I'm curious. With the genome sequencing development, Genentech's taking the lead there.
Absolutely.
Is that accelerating the advent of these new biologics? I mean,
I don't.
give me some hope, doctor.
Yeah. I don't know in regards to that if that's actually, I mean, there's a lot of genome-wide association studies that are being done, and it has driven some of the drugs, but I think the most encouraging and most hopeful to me is that we have a lot of drugs in the pipeline. You go to these meetings, I just came back from a national meeting, and there's like, sometimes you'll go to these meetings and you're like, oh my gosh, 10 of these drugs have failed, but then there'll be that one drug. You're like, wow, that one looks really good, And so this is those 3 drugs that I'm telling you, 3 drugs in the next 2 years coming out. One that may be very gut specific. I've talked about worm therapy. I'm doing research on the diet, or I'm doing research on using oral agents, antibiotics for this liver disease that's associated with IBD. I think there's a lot being done, and there's a lot of funding being put towards it, more than there used to be. It's hard to get funding when it's only affecting, when you think how many millions of people are in the country, and it's only affecting 1.5 million, that seems like a lot. But I think that's the hope. So, I mean, if you're asking for what's out there, and where is this, disease headed, I hope somebody comes up with a cure, a vaccine that we can give people.
I remembered my question.
Oh.
Is the reverse tolerance on like 6MP or Acicol?
Reverse tolerance?
Yeah.
Like intolerant, like you become intolerant?
Yeah, that's decreased sensitivity and.
Meaning you start losing responsiveness.
Yeah, like sometimes I've thought, and I've never been a vocal advocate for it. It's just when I'm driving, and I'm thinking that, well, maybe don't listen to this. That you don't take. Obviously, maintenance is the thing. But I meant if a person was to get off it, it makes the efficacy of that drug stronger. Whereas
generally people don't lose response to 6-MP azathioprine for the most part. Most of the patients that respond to it do well. 60% patients respond, period, out of people who take it. Biologics is a different story. So I think when you're talking about 6-MP, there's no evidence to suggest that you become intolerant to these drugs. Even with the 5-ACE agents, there's absolutely no evidence, no scientific evidence out there that says that people are becoming intolerant. In my practice, even if you didn't look at scientific evidence, you just said, okay, out of the patients I've treated, do I see that? I just generally don't see that. Now, the biologics are great drugs, right? It works for a lot of people, but there's roughly if you're the first time you're going to use a biologic, meaning a Remicade or Humira sort of thing, a 60% chance of responding. In the first year, half of the 60% lose response. And then you continue to lose response about 10% per year. Now, part of that is because people develop antibodies to the drug. And so there's ways to talk to your doctor about how can I prevent antibodies from forming. And these two at the 2 ends of this table, I've already talked to you about that recently, right? So, it's important to see how can I not lose response to the drug. Now, the problems with biologics now, you can't start and stop this, right? Because if you stop it and you restart it, you could get a reaction to it because you develop antibodies in that holiday period. So once you're on it, technically, I always ask people to assume you're going to be on it forever. That being said, I always say there's so much research coming out, like who knows where this disease is headed in another 2-3 decades, right? Look where we've come in 30, 40 years already. So,
it's much more hopeful.
Yeah, much more. I mean, we literally had 2 drugs. Between 1960 and 1985, there's 2 drugs. Steroids and steroids. For now. Okay, and sulfasalazine. But we've come a long way. We really have.
Just a very quick question. Do you have any opinion on zinc supplementation?
So zinc is, so I test people's zinc levels when they have had small bowel resected, or if they have active disease in their small intestine, especially Crohn's patients. And it should, we supplement it if it's deficient, so you can test for that. It's a blood test.
Part of the reason I ask is because it's something that is promoted in the health food stores, and so
Oh.
if people are supplementing extra,
Yeah, I don't
is there an
know.
indication
I don't-
that that's
I don't think it
sugar?
gets zinc tox. No, I don't know.
Well, because it's
I'd have
an
to look it up.
immune system.
Yeah, I don't know, I'd have to look it up, I don't know the answer
Okay.
to that, yeah. Any other questions? It's getting late, so. yeah.
Do you have a business card or something that if you come up?
No, I don't. I can give you, its last name is Shaw, and my clinic number is 650-736-5555.
Also, if any of you think of any questions in the next like
Yeah, and
24,
Miles
48
has all
hours,
my information.
I'll filter it through.
Are you taking your patients? I am. I'm busy, but I am.
How do you know?
I'm really busy, but I am taking
One
your
question.
patients. Yeah.
Like, I think you have been since how many patients so far?
Oh, gosh, I think about now. All I do is day in, day out, 5,000.